Thanks, Dr. Abdallah. You have seen معهد القلب before, so فأنت الخصم والحكم. Just a note for the National Heart Institute cases, we have many fellows. Dr. Abdallah knows well the National Heart Institute. We have many cases to be done, especially primary cases, and we have many fellows from Egypt and around Egypt for training. This is a simple, a complication happened at 4 a.m. and the CAS lab. Let's see what is the complication and the best thing to do, how to deal with the complication smartly. With the simplest lesion, prepare to manage major complication. Yes, it's 4 a.m., 70 years old male, known to be hypertensive. He is uncontrolled, presented by inferior ischemia, with typical chest pain 2 hours before ER admission. After rapid evaluation ER, antiplatelets, immediately transferred to coronary angio just 4 hours times. First challenge. Yes, first challenge, we have arterial resorption. Usually in National Heart Institute, the guidelines, transradial approach is preferred. Let's see a little bit about the left system. You can appreciate here the presence of myocardial breach, proximal LED lesion, which is not the culprit region, but let's see the culprit RC. I insist here to get this. It was difficult cannulation before of the arterial resorption, but we ensured that there is no damping of pressure, and we had our picture for very tight mid thrombotic RC lesion. Okay, let's go. As guidelines, direct stent, wire, stenting, excellent results. It's a very good case. How easy is this intervention? Let's do high five and next case. Excellent result. I get off ready my gloves. Please, my assistant, 100 microgram nitroglycerin, get a good picture, and get the other patient. I get out from the CAS lab. I hear 2 persons screaming, the patient and my assistant. This is what happened. Hey, so this picture, it is easy, but the patient has some chest pain within seconds. This was the result. What do you think? What happened? Is thrombosis? Dissection, yes. Yes. Let us see. But why is there a difference between the 2 pictures? Let's see this animation. Is very excellent animation. The first picture was there was a double lumen, so it was hazy here. And with time, within seconds, look at that arrow. Okay, it will go to the other side. So we shifted from this to complete obstruction. This is the danger of the dissection, or the ostial. Let us see, I had made an animation just to see what happens. This is the wire, this is the right jutkin. When we drag the wire, we hold the momentum that happened with the right coronary catheter. Let us see. The momentum get it down. Here, never inject with no pressure or damping pressure. That's what happened. This is the first cannulation. You can see how is the direction of the right catheter, and this is when we just modulated. You can see it is slightly deep just to get it, but the pressure was okay, so I can inject. So what I have to do? Regarding the algorithm dissection, most of the dissections, what happens, usually you have a wire inside. It's easy, just go a stent, go away. But the problem here, we do not have a wire inside. This is the problem. If we have able to get a wire, okay, go a stent, able to wire through the dissection, confirm this is true. If I can do this, either emergency cabbage if it's a larger artery, or medical treatment if it's small. Unfortunately, it is not a small RCA, it's a very super dominant one. What about the literature? Some cases, if you master the CTO techniques, you know we have 2 techniques through the stingray to enter the true lumen through the dissection, or the Carolino made something else. You can do Carolino technique, just insect through the microcatheter, some contrast. But I want to see something here. Every time we try to go, we go side branch, even the flow. But if I did subintrametric start technique, I may lose this conus, and the patient may go for heart block. If you were me, what would you do? Just in 30 minutes. Anyone has a clue? Just to know each other experience. What will you do this? Will you go for CTO tools, or what will you do?
So, nice case. This wire on the left is in the side branch.
Yes?
So I am in the true lumen.
Yes.
I assume that I'm true. This is an opportunity.
Yes.
So I will give vasodilator. I will not inject dye. I will just go with a second wire, and I will just rotate. And I think there is a good chance with vasodilator that he will go into the true lumen.
Okay, we will go for conservative, yes?
No.
We'll go through lumen. Unfortunately, this wire never passed except in this small branch. We couldn't go through the step.
Anyone use imaging? Any other imaging?
Okay, so I think the idea is to use the second wire also, and you can see it where it go. And the aortogram also, it's important to take the picture of aortogram, and the guide cutter is little bit out.
But what is the way of intervention you prefer to do? Two wires, yes. Okay, let us see what we have done. Actually, we know the pathology and we know what happened, so we can treat. If you know what is the problem, you can treat it. Okay, this is the problem. This is the right caster, okay, if you have the laser read. If this is the right caster, when we see this, it goes through the false lumen, and all this blue area is a false lumen. The only true lumen is that red type. What happens? Every time we go through the wire, every second wire or third wire, I will go inside this false lumen. What is the idea we have used? Okay, sorry, we used a reshaping of the caster so we can use the true lumen. This is reshaping, right caster, right coronary caster, primary curve, secondary curve. It has been by this shape. So we squeezed the hematome. This is a balloon, squeeze the hematome. For the sake of time, we use the balloon. The wire passed well when we modified the shape of the diagnostic caster, not that guiding. And finally, we succeeded. It's okay. Wow. There's a problem. We have a stent. 445. It can go through the lumen of the diagnostic. What shall I do? Now, we need a large bore. We use ping-pong technique. Let the diagnostic caster with the wire and try to get another one. So the ping-pong technique here, I got the diagnostic with balloon, and suddenly when I deflate the balloon, I can go through the guiding caster here and practice it well. Finally, my fellow was annoyed and insisted here to leave the wire to just announce to him, you can inject without a wire, but when you have good pressure. And this is final result. So we use TO technique to find the shape and ping-pong technique for simple lesion. My take home is never inject the pressure dumping. Don't panic and follow algorithm. Or always we have another plan, tips and tricks. We think we invented this, but we use at 4 a.m. I have no time to read. But we use this because we know the concept, how to get to the true lumen. Diagnostic caster type modification may be a good saving option, and this is what happened with us. But when you have the plan, you have to continue. Maintain the wire till the end. For myself, I never leave a wire for the last picture. And thank you so much.